Thank you very much for the invitation to speak at this seminar series. So I'll be giving a brief introduction to immunotherapy-related liver injury and some of the research that the liver immunology group at Imperial College has been conducting in this area over the last few years. As my introduction states, I'm a hepatology consultant at St Mary's Hospital, London. I've got a particular interest in drug-induced liver injury and the inflammation, immunology of liver inflammation in those conditions. So the title of this seminar is Immunotherapy, a Double-Edged Revolution in Cancer Care. So let's start with the revolution. Cancer care has evolved rapidly over the last decade, and I'm really looking forward to Professor Larkin's talk, as he's been at the forefront of that revolution, demonstrating the incredible impact immunotherapy can have on patient outcomes. The commonest form of immunotherapy applied in cancer care are checkpoint inhibitor drugs. Immune checkpoints are molecules such as CTLA-4 or PD-1 that under normal circumstances act to restrict immune activation and help manage the nuanced balance in the immune system between an immune system that can react to threats such as pathogens, but also not overreact to normal self. By using drugs that target these negative regulators of the immune system is biased to activation, the brakes are off, the gloves are off, and the immune system is more robust and effective at finding and destroying cancer cells. So now we come to the double edge. While immunotherapy holds the promise of durable remission from metastatic cancer in some patients, activation of the immune system can also cause a range of off-target side effects, which we call immune-related adverse events. These are a direct consequence of that overactivation that the drugs promote. These may be chronic, they may be life-altering, some of them are very rarely fatal, and they may emerge many months after exposure to the checkpoint inhibitor drugs, which is a real paradigm shift with how we think about drug toxicity, particularly in the liver. Immune-related adverse events can affect almost any tissue in the body, and I realise that the figure there on the right is probably too small for you to read the individual things, but really the emphasis is just to show how many, the multitude of different immune-related adverse events that have been described across tissues throughout the body. There's interestingly clearly an interaction between the local immune environment in each tissue or organ and that global activation of the immune system that the checkpoint inhibitor drugs cause, because while there are commonalities between the inflammation, there are also distinctions between each tissue type. Even in the liver, a single organ, we recognise two distinct patterns. Some patients have liver inflammation that damages the hepatocyte, the liver cell itself, which we call hepatitis, and other patients, more rarely, have liver damage which affects the bile duct cells, which we term cholangitis. And these two conditions have very different clinical manifestations, patterns, time course, and responsiveness to treatment, just underlying how complex this area is. Just to illustrate the double-edged nature of these drugs, I thought I'd mention a case of a patient I met in clinic, which has been partially fictionalised to prevent patient identification. So this patient, we'll call Joanne, was in her 50s when she was diagnosed with metastatic cancer, and it was unclear where the primary site of that cancer was, but it had spread quite widely through her body, and a biopsy from a lymph node had shown that that was a squamous cell cancer. She had a couple of years of conventional chemotherapy and radiotherapy with unfortunate slow progression of her tumour, and then during a clinical trial was randomised to receive pembrolizumab. This is a checkpoint inhibitor drug that blocks the checkpoint PD-1 and is one of the more commonly prescribed checkpoint inhibitor medications. Within the first year of receiving this drug, unfortunately, she started to collect a range of immune-related adverse effects that generally affected her glands. We call it a polyendocrinopathy. So she developed an underactive thyroid, which will now require thyroid replacement for life. She developed an insulin insufficiency diabetes, which presented with a life-threatening diabetic ketoacidosis and now requires insulin therapy for life. Her pancreas also stopped producing digestive enzymes, which again require replacement therapy with each meal she eats. And although that has recovered slightly, that's also impacted on her life. So then 2 years after starting immunotherapy, there was an unheralded spike in her liver function test. So the ALT, which is a marker we look at, which reflects liver cell damage and inflammation, suddenly spiked to over 700 from the normal level of 35. She required treatment with oral steroids, which brought that level down. However, when the steroids were weaned, she had a further flare up to 1,500, reflecting very severe liver inflammation. She had to be hospitalised and given intravenous steroids for this. And unfortunately, due to the severity of this side effect, she then had to permanently discontinue her immunotherapy treatment. After that second spike, she had a prolonged wean off steroids and unfortunately developed a number of steroid-related side effects, which is quite common in the patients we see who require high doses in order to dampen down these immune-related adverse events. 18 months later, having had no further immunotherapy, she had a third spike in her liver function tests after her GP had prescribed a statin medication. And at that point, when we did a liver biopsy, interestingly, the liver histology under the microscope looked very much like an immunotherapy-related liver injury rather than a statin, just showing how far these side effects can affect patients despite there being no exposure to the immunotherapy for 18 months to 2 years. However, this patient, 6 to 7 years after diagnosis, has no metabolically active disease and is in complete remission from her cancer, so has had the best of these drugs, but also has a number of life-changing chronic diseases in order to cope with. When we think of patients like Joanne and we look down the microscope and see the liver inflammation, there are a number of questions that arise. And as a liver doctor, I'm naturally particularly interested in the question of what's going on in her liver, particularly these clusters of immune cells that we see infiltrating the liver and associated with areas of liver cell death and damage. We want to know what's the identity and function of those immune cells that we see and how do they contribute to liver damage? And is there a way we could potentially treat this that doesn't rely on steroids and, as we've demonstrated in that case, have their own significant side effect profile? And so we've conducted a number of clinical studies to characterise the immune system of patients with this condition. Firstly, we looked quite broadly at the blood cells circulating in these patients, at the white blood cells, which are the immune cells of the body. We looked at across a range of different immune cells within the blood. We looked at patients' healthy controls, which are in the white circles on this graph. We looked at patients who'd received checkpoint inhibitor treatment and developed hepatitis, who are in the light blue circles on the graph, CPI-HEP. And then we also had an additional control group of patients who'd received inhibitor treatment for cancer but not developed hepatitis. And when we looked across different immune cells in the peripheral blood of these patients, we saw some changes in the monocytes, which are a particular subset of white blood cell. We looked at this marker called CD163, which is a marker of activation in monocytes, and this was significantly elevated in our patients on the surface of their monocytes. This protein can also be cleaved off the surface of the monocytes and can be found circulating in a soluble form and is quite well known to be a marker of macrophage and monocyte-related inflammatory conditions. And that was also seen to be elevated significantly compared with our healthy controls, but not our second control group. And there was some suggestion of a positive correlation between the significance of the liver damage as determined by the ALT, the liver function test, and the degree of CD163 upregulation on monocytes. And while we looked at a range of different cell surface markers, just keeping it simple, I wanted to highlight the CCR2. This is a marker again found on these white blood cells called monocytes, which is particularly important for trafficking of the cells from the blood into the liver in inflammation. And we found that those patients who developed a checkpoint inhibitor-related hepatitis had significant upregulation or increased expression of this marker on the blood. And I'll come back to that as I go through my presentation. So as I said, we looked at lots of different cell types, and we also looked at T cells in the blood. And there's a type of T cell called a CD8 positive T cell, which is named after the cell surface receptor which characterized it. We also call these cells cytotoxic T cells because they are the effector cell of the immune system responsible for cell killing. And we also found that in the blood of our patients, these were very activated. Along the top two panels here, we show two activation markers which were significantly higher in our patients with checkpoint inhibitor-related hepatitis than either the healthy controls or the patients who'd had checkpoint inhibitors but not developed hepatitis. We also looked within those CD8 positive T cells intracellularly at some of the markers associated with their cell killing function, perforin and granzyme B, and found that those were also upregulated. So circulating in the blood of these patients are highly activated T cells with enhanced cell killing capacity. We then looked at some liver biopsies of patients with this condition, and we could see the same two cell types forming clusters within the liver tissue. So to take you along the panel on the left, we have CD3, which is a stain which picks up all T cells, and then CD8, which is specific to those cytotoxic T cells, and CD68, which is a marker of monocytes and macrophage cells. And along that top panel, you can see quite dense clustered staining within the liver of patients of those cell types. And that's in comparison to the bottom panel, which is control tissue, where you see much sparser and less prominent and less clustered markers of those cell types. We were also able to demonstrate some CCR2 staining in the liver. That's that marker on monocytes that enhances trafficking of cells into the liver, and also granzyme B, which is one of those cytotoxicity markers on the CD8 T cells. When we then interested whether those clusters were co-localized, we're able to show by overlaying the CD8 and the CD68 staining, if you look at the top right panel there, that the green CD8 staining co-localized or was geographically very close to the red CD68, suggesting these cells are in close proximity in the liver, forming these aggregates and clusters of cells that we see in patients like Joanne. And so this led us to propose a model from the clinical studies by which activated monocytes and CD8 positive T cells in the peripheral blood then trafficked to the liver and formed these clusters, which were geographically associated with areas of liver cell damage. This was interesting, but obviously raised further questions about the particular interaction between these cell types and their relative roles in causing the liver damage that we saw. Some of those mechanistic things are difficult to unpick by using liver biopsies, and so we moved to work in murine models. The first thing that we discovered was that mice given immunotherapy drugs don't necessarily spontaneously develop liver inflammation unless we also give them a minor liver priming stimulus. In our model, we used a combination of immunotherapy with a compound called a TLR9 ligand, which itself causes a very minor short-lived liver inflammation, but was sufficient to trigger a robust hepatitis in mice when given with the checkpoint inhibitors. It's really interesting and analogous to what we see frequently in clinical practice in patients where a relatively minor trigger, in Joanne's case, a statin drug being prescribed, can then trigger something which looks like an immunotherapy-related effect. And we can also sometimes see this in cancer patients who are given sequential treatment, who've received checkpoint inhibitors, no later given a minimally hepatotoxic compound such as the tyrosine kinase inhibitor, and you get florid inflammation. So this necessity for a triggering event we can also sometimes see in our patients. The hepatitis that mice develop under these conditions strongly resembles that seen in humans, with increased numbers of CD8 T cells, here shown in the left of the two bar graphs, particularly at day 7, and monocytes on the right, again at day 7, with this robust self-perpetuating inflammatory response in the livers of the mice. We also histologically see clusters of T cells, CD8 positive T cells, and monocyte-derived macrophages. So looking at the day 7 at the right-hand column and down to the high power at the bottom, we can see CD8 staining in red and F480, which is a macrophage marker we use in mice to pick out cells of the monocyte and macrophage lineage. And again, they're forming tight, dense little clusters, a bit like granulomas in the liver. And I've put the human sample there on the right, showing how similar it looks there. So the mice are developing these clusters of cells, very much like what we see in the human liver biopsy. Now, I don't have time, unfortunately, today to walk you through all of the experimental results, but I just wanted to highlight a couple of kind of the most pertinent results that we then found in this model. So we wanted to know which of those two cell types was really responsible for the cell death. And so we started off by inhibiting the cytotoxic CD8 positive T cells by using what we call anti-CD8, so an antibody which takes out those cell types in the purple bar here. And we were able to show if we inhibit CD8 T cells, then we completely remove liver damage. So those cells are clearly necessary for the cytotoxicity, for the liver cell death and damage that we're seeing in the hepatitis. We then did a further experiment trying to see what happened if we blocked monocyte recruitment to the liver, and to do that, we blocked that molecule CCR2, which I've been talking about, using an oral agent called CVC, which is in this green bar here. And again, interestingly, when we blocked monocytes, what we also saw was that there was no CD8 T cell accumulation. And again, liver damage was completely removed or reversed, prevented. So the monocytes seem to be necessary for the CD8 T cells to enter the liver and cause the damage that they've seen. So returning to those questions that I asked again, although we aren't able to answer all of them in complete detail, we can say that the identity of the liver infiltrating immune cells are predominantly, though not exclusively, cytotoxic T cells, T lymphocytes, and monocyte-derived macrophages. Our mouse work suggests that T lymphocytes are necessary, now the effector cells for the liver damage, but that they need the monocyte-derived macrophages in order to enter the liver and cause that response. Some of these pathways may give us hints at targets for alternative treatment strategies to steroids, although plenty more research is required in this area before we proceed to clinical studies. I'd like to thank collaborators on this project, particularly Dr. Catherine Good, whose PhD and postdoctoral work I presented, and Dr. Evangelos Triantafilou, who's the liver immunology PI at Imperial College. And thank you very much for your attention.